Now, following procedures like a dystrophy and even procedures like a misapplication, is it a common or an uncommon complication to have a post-operative hematoma?
Sure. Bleeding after surgery is a pretty common thing that surgeons run into. You always watch and make sure everything looks like it's fine, but a lot of times when you're operating, there's not just blood vessels that can be spurting blood, there's also a lot of raw surfaces, almost like a carpet burn, that can ooze after surgery. And it's not unusual to get a hematoma in the abdominal cavity after operation.
Dr. Schwab, in this case, can we all agree that Mrs. Johnson developed a post-operative hematoma?
She did.
Is there any implication or suggestion that there was a violation of the standard of care just because there is hematoma?
No, that's a pretty common occurrence.
That's something that can happen on the best surgeon's hand?
It does.
Now, there's also been suggestion and testimony and argument in this case that the standard of care required Dr. Hickson to identify the specific injury, the specific vessel that was injured that caused this hematoma. Do you believe that to be the case?
You state that?
Sure. There's been suggestion in this case that the standard of care required Dr. Hickson to identify the specific injury to the vessel.
I have to object. That was not the project. It's a mid-stage project.
Your Honor, I think that's exactly what's been said. I'm
not
sure.
Never said that he had to identify the specific vessel that he ruptured. It was never said about the standard of care. Never said that.
As earlier, the jury will recall the testimony of this procedure. Question.
Dr. Schwab, if that is the case, that it's been suggested that Dr. Hickson needed to identify the specific injury to the vessel that led to this hematoma, the standard of care required that. Do you agree with that, or do you disagree with that?
I would disagree with that. Typically, you're not going to know what vessel it was that bled, or if it was even a named vessel. A lot of times it can be, bleeding from some almost small capillary type oozing. But no, what's important in those situations is not knowing exactly which vessel bled, but to make sure the bleeding stopped, and to make sure it's not going to ongoing. Because if the bleeding doesn't stop, you have to go back and stop it. So what's important is to make sure that the bleeding is stopped, and it's not continuing, and that the patient's stable.
Now, we know in this case that Dr. Hickson identified something on the 14th of December. Is that correct? Well, let me start that question over really quick. On the 14th of December, did Dr. Hickson identify bleeding in this patient?
I believe that's correct, yes.
Okay. And did he institute any treatment for the bleeding that he identified?
On the 14th of December, I believe the patient was transfused and she had some blood that day.
And you believe that was in conjunction with the hematoma that developed postoperatively?
Yes.
And then Mrs. Johnson was transfused again. Is that your understanding?
Yes, I believe she was transfused again around the 20th of December.
At any point after the 20th of December, is there any indication to you in the record that you've reviewed in this case that Mrs. Johnson had any additional bleeding?
I didn't see any evidence for additional bleeding.
Dr. Schwab, the jury has heard about resolving hematoma and they've heard about CT scans. So I'm going to go ahead and pull up a document, number 412. This is a document that we've all seen multiple times. It's the CT scan report from the 22nd of December 2011. And if you go down to the impression section of that, Kevin, if you'll highlight that for me. And if you read this number 2 under that, have you read that before, Dr. Schwab?
I have.
Okay. And do you have any understanding about what Dr. Hickson believed was going on with this hematoma as of the CT scan on the 22nd of December 2011?
It looked like it was, stable or resolving. The radiologist comments here that there was a complex fluid, not significant change, and represented hematoma, which would have blood negative, pancreatitis, and it basically just looks similar to what it looked like in the prior cancer.
Now, there's been talk about the sequela of pancreatitis, or the resolving hematoma or sequela of pancreatitis. Which of those do you believe is more likely going on for the hematoma of Ms. Johnson happening as of December 22nd?
Right, this was a hematoma. So radiologists, in the dark room, look at images only. And they don't really have the patient's chart in front of them. So, and they also don't ever want to be accused of not thinking of everything that could be on the list of possibilities. So they typically will go through and list several possibilities. You know, this could be this, or this could be that, or this also could be that. So that's what we see there.
Is there anything about this patient's clinical condition or laboratory values or history, anything that would suggest to you or to Dr. Hickson, in looking through this patient record, that she had pancreatitis or pancreatic involvement at this point?
Yeah, I didn't put up with pancreatitis or pancreatic involvement at this point. In fact, a few days after this, there was pancreatic enzymes checked, and those were removed.
You're talking about in the second admission?
Right.
She comes back? Was it appropriate or inappropriate for Dr. Hickson to believe this was a resolving hematoma as of the 22nd of January, 2000?
Right, that was appropriate to believe.
Dr. Schwab, one of the seminal questions in the case, was it appropriate or inappropriate for Dr. Hickson at this point in time, understanding and believing this was a resolving hematoma, to not put a drain in this Johnson?
Right, so you don't put a drain in everything